And so moving right along, before I kind of go through the algorithm of what you're going to be seeing, I want to reiterate that you're always going to be supported. So at all times, 24/7, there is going to be the ability to consult ID, and there's going to be the ability to consult an ED provider in real time. So more than likely, you'll be consulting an ED provider in real time. We're trying to make it so that you can kind of operate independently, but ED providers are always available to kind of walk you through a patient if you need to consult them prior to dispositioning. And the ultimate backstop is ED. So if at all you don't feel comfortable dispositioning this patient, you can always send them to the ED. And the ID consults are available for 24/7 for discussing whether or not a patient meets COVID testing criteria. We have an algorithm for that as well, so you can kind of self-serve and figure out, does this patient meet testing criteria? If for some reason after you use that algorithm, you can't tell if the patient meets testing criteria, you can always call ID. They're available 24/7, even though we really only operate until 11 p.m. They are available for you to talk to them at all times. And other thing I wanted to reiterate is, again, your safety. I want to ensure your safety, and we do that by all that PPE that we're wearing, but we also do that by minimizing close contact with the patient. And so we know from the paper and the papers coming out of China and the data coming out of China about COVID, that the physical exam is generally non-specific. And in these asymptomatic to minimally symptomatic patients, very rarely does it change your management. So what we're dealing with, again, is patients that are ambulatory, that have a normal respiratory vital sign, normal respiratory rate, normal O2 sat. And so these patients, going up to them and listening to their lungs or looking at their mouth, they're doing all this stuff is really not going to change your management, because they're, again, mostly the worried well. And so if the patient had abnormal vital signs, that patient goes to the ED. It's not somebody that you're going to have to deal with. And we're always kind of encouraging empiric treatment of things. So if for some reason you're like, look, I know this patient has normal vital signs, I know they have a normal O2 sat, but they have a history of asthma, I want to know if their lungs are wheezy, because then I want to know if I need to give them albuterol or something. If that's a thought that goes into your mind, then just do an empiric treatment, meaning give them albuterol if they don't have it at home. Have them try it out for a couple of days. If it doesn't work, they can always come back. Or if it does work, hooray. Or if it doesn't work, they can call their primary care doctor and have somebody reach out to them via telehealth. So that's what I mean by empiric treatment, is if you have a thought in your head of like, oh, I don't know if this patient maybe has a pneumonia or something, and we can do empiric antibiotic treatment. This patient might be wheezing. Fine, just do empiric albuterol. Again, what we're doing is rapid triage, sick versus non-sick, and what you're trying to determine is this patient going to be well enough to survive over the next 2 to 3 days based on my rapid evaluation. Any questions there before I start going over who we're testing for COVID? Okay. Actually, before we go over who's testing for COVID, we created a little management algorithm that you can deploy whenever you're seeing patients. After a while, this will become second nature. So what is a general workflow for you as a provider in the tent? So what I normally do is I review the vital signs first. So you'll have a set of vital signs. Everybody gets a temperature. Everybody gets a pulse ox reading, and the pulse ox reading gives you the heart rate as well. And the nurse is calculating the respiratory rate. We're not routinely getting blood pressure on everybody, because again, these are ambulatory patients. So if they're not reporting any sort of orthostatic symptoms, meaning like weakness, dizziness, pre-syncope type symptoms, we're just assuming that they have normal blood pressures, and that's fine. If they report any of those symptoms, then we'll get a blood pressure, but we're getting a temperature, a pulse ox, a respiratory rate, and a heart rate on everybody. So I take a glance at those, and then I go and take a look at the patient, right? So the first step in this is determining, is the patient ambulatory? Yes, no. And I really should change that, and I will change that too. Is the patient at their baseline ambulatory status? So we are getting some patients who are normally wheelchair dependent. And so if they started off wheelchair dependent and they're wheelchair dependent now, then you can see that patient. But most of the patients that we're seeing are going to be, walking around. So if yes, go to the next step. If no, pass go, you can go straight to the ED, because we're not going to have you evaluate those patients who are not at their baseline ambulatory status. The next step is the patient obviously sick appearing? And that means, like, do they look like they're in severe pain? Are they visibly tachypnic? Are they somnolent? Are they diaphoretic? So theoretically, these patients really shouldn't be making it back to you, because the RN screener should be screening these out. But sometimes some of them do fall through the cracks. So if you notice somebody who's like in severe pain or diaphoretic or visibly tachypnic, then you can go send them straight to the ED. If not, you can go to the next step. And the next step is checking the focus vital signs. So you've already kind of done this. And so basically, any abnormal vital sign, ignoring the blood pressure for now, but any abnormal, because you're not going to have that on everybody, any abnormal vital sign listed here, go straight to the ED. So we're not going to have you see any hypoxic patients. We're not going to have you see any tachypnic patients. We're not going to have you see any significantly tachycardic patients. And then we're not going to have you see anybody with a low blood pressure. So if any of these are abnormal, go straight to the ED. If not, then you get one more step to go. And the next one is, does the patient have a fever? And so I'm going to tweak this a little bit. This was originally devised for medical providers, so PAs, NPs, MDs, DOs. And I was having them, look at the temperature, but, not look at the temperature in isolation. So yes, having an elevated temperature is an abnormal vital sign, but in it by itself doesn't really dictate what you can do with the patient, because I can have a sore throat, runny nose, and a cough from a viral infection and look fine, just like I look now, and I can have a fever from that, right? So I was telling them, I want you to look for fever and, right? So fever and signs of a localizing lower respiratory infection, like coughing, chest pain, shortness of breath, or fever and a rash that looks like a cellulitis, right? Fever and any of the surge criteria. So if they have fever, tachycardia, and hypoxia or something, then those are concerning. But for you guys, I'm going to change this actually to just any vital sign that's abnormal. I don't want you to deal with that alone. And any vital sign abnormality, I want you to kind of consult the ED for that, so that we can kind of together come up with a plan that we all feel comfortable with. And so if you see anybody with a fever, even though if they look great and they're giving you a thumbs up sign, I still want you to talk to the ED until you've worked enough to where you feel comfortable. Again, you're always going to be supported. I don't ever want you to feel uncomfortable making clinical decisions, and we're always there as backup. So I'm going to modify this a little bit, but again, abnormal vital signs goes to the ED, totally normal vital signs goes to you. And this next category is more of a reminder to just think a little harder for these patients. It doesn't necessarily mean that anybody who meets this quote unquote wild card criteria needs to be sent to the ED. I just like it as a nice little mental reminder to stop and think, okay, does everything check out, right? And so what are these wild card criteria? What are the wild card patients? So anybody who's over the age of 65, anybody who's immunocompromised, anybody with significant lung or heart disease. So any of these patients who, by the CDC criteria, would be at risk for severe COVID disease. They might not look bad now, but these are the ones that may have a severe clinical course. So we want to make sure we're extra careful with them. So it doesn't necessarily mean you need to admit these patients. It doesn't necessarily mean that you need to send them to the ED. But it may mean that we need to arrange a closer follow-up and making sure that we're ensuring that somebody is touching him on the back end, either through telehealth or a phone call. And then the last one is really digging deeper into any acute shortness of breath. So they might not have reported it on review of systems. I like to just, as my last thing that I ask patients is, are you having any shortness of breath? And if so, let's dig a little deeper into that. Is it such a clinically significant shortness of breath that it's affecting your activities of daily living? Most patients that we've been seeing in the tent say no to this question. But the reason I'm kind of including it in this algorithm is because the primary presenting symptom for people with clinically significant COVID disease is a respiratory symptom. The ones that were actually need admission, it usually is from a respiratory symptom. Not so much from like the URI kind of symptoms that you get, the stuffiness, the sore throat, or the myalgias, that like the influenza-like illness symptoms. It's like I'm pretty symptomatic from a shortness of breath standpoint. And so I like to just kind of ask that last. Any questions there? Okay, and as my kind of last, that last part of the algorithm dovetails into how to further triage dyspnea. So I know that a lot of the providers working the tent have been reassigned from their primary clinical duties. Therefore, we have been using this script to try to determine, okay, you're short of breath, right? So patients can subjectively say whatever they want, right? And it's our job as providers to objectively determine, is this clinically significant, right? And at one end of the spectrum of dyspnea, you have people that are so short of breath that they can't do activities of daily living. So they can't dress themselves, they can't feed themselves, right? They can't even go to the bathroom, right? They can't get out of bed, right? Those are not patients that you're seeing, and those are not patients that you have to worry about in the enhanced screening tent. You're sending those straight to the ED. At the other end of the spectrum, which is the majority of the patients that you'll be seeing, is patients that feel short of breath subjectively, but it's not really limiting them in any such way that's significant, right? So they don't feel like normal, like their baseline, right? Just think back to when you've had a cold or when you had a really bad flu and you felt really stuffy. You're like, yeah, I feel a little stuffy, I don't feel totally normal, but I'm still kind of doing around, playing video games, going around, and not really, it's not really limiting me in any way. The other thing I like to do when I'm trying to triage these patients that report dyspnea is I ask them an open-ended question to start off with, and I just let them go. Don't say anything. Let me see how long they can talk. And if they're able to just kind of just keep on talking in multiple word sentences without me even breaking in and stopping them, that's actually pretty good. The next thing I like to ask them is, just because most of these patients are parking pretty far away, is like, hey, where did you park and how did you get to the tent? If they walked all the way from the other side of campus to come back to the tent and didn't really report that as an issue, that's also another marker of this not potentially being a clinically significant thing. And I'm asking you to ask these questions, not so much so that you're like, hey, independently discharging these patients. You have that option if you feel comfortable, but it's more so you can have this data gathered in the event that you need an ED consult to definitively disposition this patient. At least we have that information already, and you can report that to the ED doctor, and you can quickly together come to a disposition plan. And I think eventually, if you start working in the tent enough times, this kind of becomes second nature, and you'll see in action. It's pretty easy and straightforward to kind of further triage patients' reported subjective dyspnea and determine objectively how significant is this. Any questions there? Because I know I kind of threw a lot at you. Okay. And so step number one is determining sick versus non-sick. We went through that. We have a management algorithm that we're going to edit a little bit for you, but overall, this is kind of what it's going to look like. And then went a little bit in detail as to kind of how you further triage dyspnea. The next thing that we do in the tent is determine who gets tested, right? Do we need to test this person for COVID? Yes, no.